Greetings. It's a great pleasure to be with you today discussing very important concepts during this COVID-19 pandemic. As vascular technologists, you're some of the most valuable healthcare providers in the area of thrombosis, and it's a great pleasure to be able to present these data to you. Now, as you realize, thrombosis is a very important topic. And there's one thing here that often doesn't get really appreciated very much, and that is that fatal pulmonary emboli are the number one preventable cause of death in hospitalized and surgical patients. There's a lot of surgical complications that you can't do anything about. You do a great operation, but the patient leaks of the anastomosis or they bleed or something like that. But fatal pulmonary emboli are generally preventable. You can prevent almost over 99% of them if you apply appropriate anticoagulation prophylaxis for the period of time that they're at risk. And risk scoring identifies who's at risk for these emboli and guides the physicians. And also providing prophylaxis for the entire period of risk is important, not just when they're in the hospital. They may go home with increased risk, and you have to account for that. Now, we have come up with a risk assessment schema, and it's due to a lot of brilliant people around me that have helped put this together. But one of the real nuggets of information that I learned many years ago is I had the good fortune to know Maxwell Boro, who was chief of surgery at Somerset Medical Center and Seton Hall. And he did some very important experiments in patients. And in those days, you did fibrinogen scanning to see if there were hot spots in the leg. And then if you found a hot spot, you did a venogram. So all of his data is venographically based. And he showed that patients who have the length of surgery, the risk goes up. With age, the risk goes up. And then the blockbuster comment that's still not appreciated today because oftentimes patients aren't even asked about this. 66% of patients who had a past history of a VTE and had an operation got a recurrent thrombosis postoperatively. Very, very powerful information. And, you know, you've got to know history. And they say, oh, this is old data. This is sterling data because it was venographically based. And I'm not saying it's 66% today because things have improved. Now, why did we come up with this Caprini score? Well, this is nothing more than a thorough history and physical with 40 elements. And we know as the number of risk factors goes up, the incidence of DVT goes up. We also know that each risk factor has a different, risk factors have a different power. For example, bed rest is low risk of thrombosis, whereas cancer of the pancreas is high risk of thrombosis. So taking those weights and putting those weights together and combining that with the number of risk factors, we come up with a number. And that number has now been tested throughout the world in over 5 million patients. And that number represents a nonlinear increase in the DVT rate, the clinical DVT rate. So as the number goes up, 2, 3, 4, 5, 6, 7, the incidence of clinically relevant DVT goes up. And if you take a look at that, this is the figures in general surgery. And we know that everybody has unique risk factors: obesity, cardiac or pulmonary disease, cancer, family history of blood clots or strokes. You can't put all patients into one basket. You've got to do this risk score that is predictive of a thrombotic event. And one of the most important things about this is the fact that many people don't need prophylaxis because their risk isn't high enough. And other people not only need prophylaxis for 5 to 7 days, but maybe for 2, 3, or 4 weeks afterwards. And so one of the things that we're trying to do is to encourage everybody to do their own risk assessment, like after this meeting, get the form and then take it to your doctor, validate it, and put it in your patient chart. And you should huddle with your loved ones to complete their score, thoroughly evaluating the risk factor in the score. Family physicians should be consulted to verify the score and then keep the score in a safe place. Most important is having loved ones aware of the baseline score so the patient come in coma from trauma, a stroke, can't talk, auto accident, or God forbid, COVID-19. You come into the hospital short of breath. You may have be seriously ill, have to go straight to ICU. Nobody's going to sit there and ask you 40 questions, including did your grandmother die of a fatal pulmonary embolus? Won't happen. But if it's missed, that could be the difference for you between life and death. And this is really important, not only at the time of admission, but remember that as the hospitalization goes on, it's important to rescore the patient. Now, we have a patient-friendly version that's been validated in multiple languages. And here is the patient-friendly form, and it's very easy to use. There's two things I'd like to point out which are specific, and these are unique. This first one is unique to the Caprini Risk Score, and that is we ask questions about women, not only about birth control, but pregnancy-related complications, unexplained stillborn infant, 3 or more spontaneous abortions, premature birth, and also those children that might have low birth weights, toxemia of pregnancy. All of these things may signal an antiphospholipid antibody syndrome in the patient. And long after they have their child obstetrical history, they still may carry that risk assessment. And Ben may even have been there the time that I was sitting in the room and they were discussing it, morbidity and mortality, a patient with colon cancer who had a DVT. And I said, what is the patient's obstetrical history? And the chairman of surgery, who's a very powerful man, turned around and said, Joe, we're not talking about this lady having babies. She has cancer. Well, but that's not the point. The point is that if she had one of those obstetrical complications many years ago, she could be carrying the antiphospholipid antibody syndrome. Beta-2 glycoprotein, lupus anticoagulant, or anticardiolipin antibodies. They're very powerful predictors of thrombosis, and often they're the difference between life and death if that's missed in the patient. The other thing that's missed is family history, including in all 3 degrees of relatives, and that's a very important thing to understand. And how many times have you been, any of you been to the doctor, or if you've had surgery and your people are screening you, and especially the ladies, have they asked you these 2 questions, including family history of thrombosis and obstetrical history? Very important. As I said before, as you're going through the hospitalization, the score needs to be updated because it's a dynamic instrument. I had a patient come in with an appendix, and they operated on the patient. And when they operated on the patient, they found that so this patient was over 40, which is 2 points, overweight, which is 1 point, and having surgery, which was another 2 points. So now that's a 5. So that's right on the border. But then they discovered peritonitis, and they couldn't operate on the patient. Laparoscopy had to convert it to an open. The next day, the patient leaks, and then they had a drainage procedure. And then because of the IV antibiotics, a PICC line was inserted. There's more points, and then the patient gets pneumonia. There's more points. Then the wound falls apart due to the infection, so the patient is non-ambulatory. And everybody was shocked when this patient, who was so-called Caprini low to moderate risk, died. Well, the answer was that nobody updated the score during hospitalization. Now, one thing that's really important is that we've always been told, and the American Academy of Orthopedics is very vocal about us not routinely screening preoperative patients. And I would say is that Jim Caderna never really published this, but Jim Caderna has single-handedly, as you know, Jim Caderna was a famous orthopedic surgeon who did 18,000 total hips during his time at Northshore, a wonderful surgeon and human being, great clinician. And he had a preoperative screening routine. And I personally was involved with him, and we've saved over 40 patients' lives by doing preoperative scans. Nevertheless, now, finally, we have a group where preoperative scans are indicated. And this comes from Thailand. And this is in a patient group that has hip fractures. And 16.3% of them had a clot because they were all scanned preoperatively. And it was recommended very high sensitivity and specificity for the Caprini score, not so much for the Wells score. And the bottom line is, if the patient has a score of 11 or 12, you really should do a preoperative scan because you're going to have a high yield of preoperative thrombosis. Now, duplex scanning during COVID-19. There's no question that this is a very important modality, and there's lots of patients with COVID-19 who have thrombosis. But there is a challenge here to provide timely testing while minimizing the exposure to vascular lab personnel. And we're really concerned about that. Eugene Zeeler is a very prominent RVT, and he's done a lot of work in this area. And he has told us and given us some suggestions here, and encouraging the use of D-dimer and pretest probability, and algorithms for diagnosing. And I worked with Ben, and Ben put together a very careful algorithm for the Northshore hospitals, which I think probably has been working well. And the other thing is that, and this I must say, performing limited examinations, especially when you find a proximal DVT, not to go ahead and do the whole distal exam. And the complete duplex exam. Now, when I started the lab, and Gail Size was one of the technologists, wonderful technologists that I learned a lot from, we worked together for many years, we would sit in a room and look at a tape of one leg ultrasound for an hour. And then after that, call the doctor and give the doctor our report. So we have long had a tradition of doing complete leg ultrasounds and looking at everything. And now that's what you all do. And it's the societies actually endorse it. But I'm going to start some comments that I never thought I would make, but I think during COVID-19 they're probably important, and that is the 2-zone compression ultrasound for proximal DVT. In many parts of the world, that's all they do: a compression ultrasound in the groin and compression ultrasound in the popliteal fossa. And as you know, one of the philosophies is that those proximal veins have a high risk for pulmonary embolus, and the distal veins have a low risk for pulmonary embolus. So this is it. And this is like all of you technologists sitting there say, "Ye gods, this is the exam." But nevertheless, under certain circumstances, in certain populations, and in certain parts of the world, and especially in COVID-heavy areas where you just cannot do what we normally do, this is one of the things that can be done. And this is simply visualizing the thrombus in the vein lumen, non-compressibility with direct pressure, and color flow and Doppler waveforms not done. And this is sort of a picture of how it's done. And this is mainly to teach the people that are not like this group about what to look for. And this was taught to ER physicians with a 10-minute training session, comparing 2-point ultrasound by the ER physicians with the standard duplex exam. And in this particular case, all 45 proximal DVTs found on the full scan were identified by the 2-point ultrasound. One patient with a negative duplex had a positive compression ultrasound. Very interesting. And here's some more data with a high degree of specificity and sensitivity for this exam. So final thoughts for this part of the discussion is screening for proximal lower extremity DVT with 2-zone compression ultrasound is sensitive and specific. Limitations: it's not going to detect below knee calf thrombosis or iliac vein IVC thrombosis. False positive compressions with venous hypertension are certainly possible. A normal exam can be repeated if the clinical suspicion remains high, or then you can go to a full exam, and a non-diagnostic exam should be followed up with a complete whole leg duplex. The 2-zone compression ultrasound can be combined with D-dimer and pre-test risk stratification. I would also add that doing a point-of-care ultrasound testing with a portable device in either a tablet or your phone as the recording device or the visualizing device certainly would minimize taking those beautiful machines to those locations and subjecting that to all the time and energy has to be done to try to clean the machine and so on and so forth. So last year, some of us at the American Venous Forum got together and talked about considerations in prophylaxis and treatment of COVID-19 patients. Elevated D-dimers follow the severity of the disease and represent a marker. Ultrasound screening is unnecessary if the D-dimer is negative. High D-dimers should not be the sole indication for a duplex scan. Venous duplex exam indications should be similar to the non-COVID-19 patients: pain, leg swelling, erythema, and so forth. A normal venous scan should not be used as a marker that anticoagulation is unnecessary. One of the incredibly nightmarish features of COVID-19 is it's an endotheliitis, and it affects blood vessels all over the world, all over the body, and therefore you can have primary pulmonary thrombosis without pulmonary embolus, where clots forming and that can happen anywhere in the body. So just because a venous scan is negative doesn't mean anything as far as systemic thrombosis. And patients treated with full anticoagulation should not be scanned except to answer a specific clinical question, and we recommend the point-of-care ultrasound screening in COVID-19 patients. Here is the algorithm: inpatient for COVID-19, Caprini score and D-dimer. If the score is over 8 and the BMI is high and the D-dimer is 3 times normal, we double the dose of anticoagulation. And now there's emerging data that's agreeing with us. In the beginning, you'll see, we'll talk about that later. If the patient has DVT signs and symptoms, then you do point of care screening. If they have a DVT, you therapeutically anticoagulate them. No DVT, continue prophylaxis. Now, on the other hand, in patients, that's patients with less than 8. And now, if patients are more than 8, then they get double the dose of anticoagulation. And if the D-dimer is 3 times normal, in our case, we recommended therapeutic low molecular weight heparin. Now, the other thing is discharge considerations. Patients with documented VTE, therapeutic anticoagulations, standard, 3 months and reassess. If the score is 8 plus and the BMI, including the BMI of over 35 or the D-dimer less than 3 times normal, we put them on a direct oral anticoagulant for 6 weeks. If the D-dimer is normal, 3 times normal, then they stay on therapeutic heparin or low molecular weight heparin, and in 2 or 3 weeks, then follow them with a duplex ultrasound, and then separate them into those that have DVT and no DVT. And as you can see, the 3 months of anticoagulation, or continue the DOAC for 6 weeks. Now, coronavirus and thrombosis. What do we know so far? Well, first of all, and this was kind of shocking to me when I looked it up, I was sitting there making this slide, and I saw that. So I looked up the statistics, and in January 12th, there were 22.9 million people in the United States suffering from the coronavirus, including 380,000 deaths. From that time until February 11th, when I made this slide, the deaths went from 22.9 million in the United States to 27 million, the cases. And the deaths went from 380,000 to 471,000. You'll notice worldwide 107 million and 2 million, 3 deaths. No surprise, the United States, India, and Brazil have the most infected patients. Now, we know that coronavirus presents with flu-like symptoms, serious infection, sepsis, organ failure, pneumonia, respiratory failure, deep vein thrombosis with swollen, painful legs or arms. Post-thrombotic syndrome can occur. Pulmonary emboli, pulmonary thrombosis, respiratory failure and death, and arterial thrombosis with limb or digit loss, stroke, paralysis, and death. The presence of additional risk factors compounds the likelihood of a poor outcome. Those people that are just putting everybody into the same bucket, it's like putting everybody in that room where I'm talking to in the same shoe. That just doesn't make any sense. It never has, it never will. You've got to individually assess patients. Now, what happens with COVID-19? There's a virus-induced inflammation that triggers a cytokine storm causing tissue factor release, thrombin generation, fibrin formation to coat the virus and prevent spread. And that's really a cool mechanism, isn't it? We're going to coat the virus with thrombin, with fibrin, and then prevent it from spreading. But unfortunately, the side effect is thrombosis, and it's one of the hallmarks of this disease. The activation of thrombin and hypercoagulability is reflected in the D-dimer. As we said, DVT, pulmonary thrombosis, pulmonary embolism, stroke, non-hemorrhagic stroke, arterial thrombosis may occur. Microthrombosis may occur in the lungs, kidney, liver, and brain. Fibrinolysis may occur to dissolve these thrombi. And in some cases, a DIC-like picture can result in thrombosis or bleeding, depending upon the relative production and consumption of clotting factors during the disease. Now, this virus has a predilection for the pulmonary circuit, and in particular, you're looking at the beautiful alveolar endothelial interface, which is the secret of life. And as you know, oxygen and nutrients and waste products are exchanged here. And when the virus attacks, one of the systems that gets activated, we'll talk about these systems in a minute, is the kinin system with kallikreins. And as a result of that, you get increased vascular permeability, vasodilatation, bradycardia, hypotension, shock. But in addition to that, facilitated by the ACE2 receptor binding to the spike glycoprotein of the virus is like an arrow, and that arrow pierces endothelial cells and pierces this endothelial alveolar junction. and this can pierce these cells anywhere in the body. And as a result of that, damages, of course, the endothelium, and as a result of that, there's a pulmonary dysfunction. Pulmonary thrombosis can occur. Pulmonary hemorrhages can occur in some of these capillaries, and the typical ground glass appearance on chest X-ray can be seen. Now, again, I love history. We have to go back to history. I had the good fortune to, I was, Northshore was at Northwestern for many years. I worked with the Northwestern Bioengineering Department, and I met Laszlo Lorand, who discovered factor 13. And Laszlo Lorand introduced me to Oskar Ratnoff. Now, Oskar Ratnoff was a famous hematologist. He was a premature infant that was born, and his father was a pediatrician, and his father was advised to let him die because he was so small. And no, his father nursed him and hot water bags and so on and so forth, using all his skills. And so Oskar Ratnoff turns out to become one of the most famous hematologists ever in the history of the world. First of all, you've heard of the clotting cascade, factors 12, 11, 10, and have 8 and 9, 5, 10, and calcium and so forth. Oskar Ratnoff, along with a man named Davies, came up with the clotting cascade. And in fact, Oskar in his later life lamented the fact that he didn't get the Nobel Prize for that. But Oskar Ratnoff came up with a theory called the tangled hemostatic web, and he presented this at grand rounds in Frank Auditorium at Evanston Hospital as my guest in the 70s. And what he said was that there are 4 experiments done before the turn of the 20th century that proved that contact activation of the blood triggers multiple systems. And he was studying this contact factor, factor 12, because he had discovered a patient, John Hageman, who had an abnormal clotting profile. And he sorted this out. It was due to a deficiency in factor 12. And what he said was, when factor 12 gets activated, factor 12 then activates platelets with platelet plugs, coagulation, production of thrombin, fibrinolysis, and you have D-dimers and fibrin split products. But activation of the complement pathways, the inflammatory pathways, with IL-1, IL-6, and those pathways of inflammation activated. Cytokine storm, that's where this comes in, but also the kallikrein system, kinins, bradykinin, PF-DIL, slowing of the heart rate, increased vascular permeability, vasodilatation, angioedema, histamine release, hypotension. Good Lord, what a collection of symptoms. Now, what he said was, and this is worth reading because I can't duplicate what Oskar said so well. I'm sorry, operator error. Thesis of my talk is not new. We think about clotting, fibrinolysis, immune reactions, and inflammation as if they were separate and separable processes. We hear that all the time with COVID-19. Oh, it's a cytokine storm. Oh, it's thrombin generation. In truth, these distinctions are man-made. In the real life, it is the body as a whole that responds to this injury. The processes through which it defends itself are interlocked like pieces of a jigsaw puzzle. We may be intrigued by the intricate pieces of the puzzle, but the picture emerges only when they are put together. And just remember, for these reasons, this is a nightmare. This COVID-19. It's Oskar Ratnoff's tangled web on steroids. Although you use steroids sometime for the inflammation, but anticoagulation alone is not the answer. So now the American Society of Hematology and their 2021 guidelines on the use of anticoagulation for thromboprophylaxis in patients with COVID-19, they have recommended prophylactic intensity anticoagulation over intermediate intensity or therapeutic intensity anticoagulation for patient prophylaxis in patients with COVID-19. Now, a lot of us have found that advice, and this really was first published in October, but when it came out in print, it was 2021. That's not how many people around the world have reacted. I will give you an example of how frustrated we were when we saw this come out. For example, I reviewed an article that came out of New Orleans, 6,000 patients, famous investigators, COVID-19 patients. They followed the prophylactic guidelines which was to give everybody standard prophylaxis with no escalation unless they had a proven clot. 50% of the patients had breakthrough thrombosis. And yet the authors at the end of the article said that we still adhere to the policy of prophylactic anticoagulation. I don't understand that. But there are many investigators around the world that have not adopted that policy, because when COVID first hit, when COVID first hit, there was a debate about, well, should you even really give low standard anticoagulation prophylaxis, which is like 40 once a day or 30 twice a day of a low molecular weight heparin. And finally, people started to see all this thrombosis, so they said, okay, we've got to give these people a standard prophylaxis. And then that's when we came up with the American Venous Forum, and based on a lot of experience, especially out of New York early, where they were having a lot of breakthrough thrombosis. So they started to escalate the dose and double the dose, and especially for certain indications. And if you look carefully in the guidelines said if the patient has a BMI of over 40, you ought to consider doubling the standard prophylaxis. Well, what's the difference between a BMI of over 40, a past history of thrombosis, cancer, a family history of thrombosis, inflammatory bowel disease, or other comorbidities? So that's why the American Venous Forum panel, we came up with the thing that let's use the score to differentiate those people who have lower and higher risk of thrombosis, and based on that evaluation of their level of risk, then give them anticoagulation accordingly. And so they recognize the need for high quality randomized controlled trials comparing different intensities of anticoagulation. Now, I'm not the brightest bulb on the tree, and who am I to say anything about these brilliant investigators that came up with these guidelines? But what am I missing here? In the entire history of medicine, and in the history of taking care of patients, and the history of taking care of patients with thrombosis, what have we learned about taking care of thrombosis patients? We've learned a tremendous amount about how to handle patients with to prevent thrombosis, and all of that knowledge and all of that data. It's all of a sudden like, well, we're going to put that on the shelf now because we need randomized controlled trials. Where is the statement that says that experience based on randomized controlled trials that appeared before the onset of the COVID-19 can be used as a surrogate for therapeutic decisions until we have high quality randomized trials specifically related to COVID-19? I missed that statement, but maybe one of you can help me. I don't understand why we can't use what we've learned over our lifetime to help our patients. And they also acknowledge that these are conditional recommendations that may be followed by the majority, but not all individuals. Well, hey, wait a minute. When you put out a set of guidelines, people tend to follow the guidelines, and for a variety of reasons, including medical legal reasons. You didn't follow the guidelines. Let's say you gave more anticoagulation, the patient bled to death, the grieving widow is in knocking on the lawyer's door. So that you've got to be very careful about what recommendations are made and what's in the main print and the fine print. And this is a little diversion, but the classical, to me, misstatement out of CHEST 2012 was the statement that we don't recommend routine thrombosis prophylaxis for patients with lower extremity fractures, distal fractures. And that statement was based on average risk trials with average risk patients. And when you have high risk patients, those patients need anticoagulation. Now, they said in the fine print that we recognize that these recommendations are based on average risk patients. So those patients who are at higher risk, such as those with a history of DVT or cancer, may merit thrombosis prophylaxis. So the authorities and the lawyers used that statement to say, we had a patient with a crush injury because they got hit by a car on a bicycle, had a tib-fib fracture. Well, this patient wasn't a candidate, and the guidelines say it. And Dr. Gertz came and testified to the fact that they didn't recommend routine prophylaxis in this case because the guidelines say that. And what about those with extra risk factors? Well, if the patient didn't have DVT or cancer, it just got hit by a car, so that doesn't qualify. That has always bothered me because that doesn't make any sense at all. Any high risk factors at all would qualify for thrombosis prophylaxis. And so Then they come out with a statement that the individual assessment of the patient's risk in thrombosis is important when deciding on anticoagulant intensity. And again, I would say that why didn't you put after that? Based on all the information available before COVID-19 and randomized trials, you can use those data as surrogate markers for your current practice until further data are available. All right, enough of that. Now, COVID-19 and anticoagulation, they were just released. This was just released on January 22nd. There's these 3 big trials that are going on to answer this question about anticoagulation in COVID-19 called the NIH multi-platform. And what's interesting is that I don't know all of the details of all of these trials, but as far as I can see, there's very little, if any, risk stratification in this. This is sort of one size fits all. Nevertheless, what they found was, first of all, let's talk about the ICU patients. And in the ICU patients, they found it difficult to come to any kind of a decision based on the severity of those patients and their incidence of thrombotic events and their incidence of bleeding events. So now they focused in these trials, and what their announcement was based on the moderate patients, and that meant the patients that were on the wards and weren't in ICU. And as you can see here, the need for organ support was statistically significantly lower in patients who got therapeutic anticoagulation versus the standard anticoagulation. And the mortality was also higher with moderate state. Mortality was higher for those patients who weren't in ICU but got the standard anticoagulation and not the high dose. The high dose reduced the mortality and reduced the thrombotic events and was only associated with a small increase of major bleeding. So, what is a small increase in major bleeding compared to a death? And there were scattered reports. There were scattered reports throughout the literature up to now, too, that higher dose anticoagulation protected some patients and did lower the mortality, even some of the ICU patients, but it was hard to sort out. Nevertheless, sorry about that. Nevertheless, the NIH announced that full dose anticoagulation is superior to the usual care prophylactic dose anticoagulation in reducing the need for organ support in mortality in moderately ill hospitalized COVID-19 patients. Hallelujah! All of those investigators from all over the world, all of the other guidelines out, including the American Venous Forum guidelines and other guidelines that recommend escalating the dose under certain circumstances, now have some breathing room. And now we're beginning to see what's really going on. So now let's go back in history. And this study was based on the Riete database. And the Riete database I can't tell you in Spanish because I don't speak Spanish, but this is a registry of patients from 132 countries. There's now 90,000 patients in the registry and over 100 peer-reviewed publications. And what this registry is and we were the first hospital in the United States. I started this, and Alfonso has carried it forward in a big way. Hats off to Alfonso on many fronts, and also my esteemed vascular surgical colleagues, especially Benjamin, who is here with us today. And my fellow, so what the Riete database was is those patients that had DVT, the doctors were invited from all over the world to put their patients in the database, tell us what their risk factors were for the clot, how they were treated, and what the outcomes were. Real world data. And based on this real world data, a number of interesting conclusions, of course, can be made. And one of those conclusions was that patients who leave the hospital and eventually get a clot, these aren't all patients who leave the hospital, but those patients who leave the hospital and get a clot when they later, let me back up a minute, I'm saying this wrong. A patient in the database that got a clot, 77% of those patients got their clot after they went home, and half of them after anticoagulation was stopped. And this was published in 2008, and it was published by Juan Arcelis, who was a fellow at Northshore here for 3 years and worked with me, and brilliant investigator. And what we found, of course, were that high Caprini scores received extended prophylaxis. That was an ideal place to do that. 2008 now. So COVID-19 introduces a whole new level of complexity in these patients. And what do we know now? What have we learned? And this is data before COVID-19. Betrixaban and rivaroxaban, two oral anticoagulants, were shown in hospital and extended thromboprophylaxis in high-risk medical patients at low risk of bleeding. So they were shown to be very efficacious in preventing thrombosis following discharge in the high-risk group, and that affected more than 25% of the medically ill population. 60% of all VTEs, according to other statistics, show that they occur after hospital discharge, with 80% of them occurring within 6 weeks. Despite these data, this is incredible. Less than 4% of patients are sent home on prophylaxis. The symptomatic VTE rate more than doubles during the first 3 weeks, and there's a 5-fold increase in fatal events within 45 days. And here are the trials: ADOPT, Magellan, Mariner, and Apex have all shown the value of both betrixaban and rivaroxaban for the prevention of VTE in the medically ill after discharge. And the PADOA score, the improved score, and the improved D-dimer score, which are all approved in medical patients, but they're less sophisticated than the Caprini score because they only measure 8 or 11 elements. But nevertheless, that's a good. They're good scores. They've been used around the world. They're used by a lot of people, and they've been used to separate out those people that are more likely to get a benefit from the anticoagulation and not. So bravo. So now wait a minute. COVID-19 magnifies all of these statistics. So why aren't we having statements that say that we should apply the data learned from the COVID-19 from our previous history to the COVID-19 era, where we know these patients are even at more increased risk of thrombosis? And not only that, but we can assess those people and divide them up and give them appropriate prophylaxis. We know that 1 out of 8 COVID patients that's been in the hospital goes home with serious comorbidities. They're weak, they're tired, they can't breathe right, they can't smell, they can't taste. There's all sorts of problems that occur in these patients, and of course, getting thrombosis. So now, based on all of that, there are 28 trials going on, and I'd just like to show you the brief thing about one of the trials. Eduardo Ramacati from South America is involved, I believe, in 32 trials. He's an absolute genius. I don't know when he goes to sleep, but he's provided some of the most important information. And if you see his presentations online, he's an absolutely brilliant investigator. And he's the organizer of the Michelle trial. And the Michelle trial stands for medically ill hospitalized patients for COVID thrombosis extended prophylaxis with rivaroxaban therapy. And this is where they're taking patients and they're using the improved score, which Alex Spiropoulos, who's another famous investigator, has developed and validated very, very well in medically ill patients. So the improved score with a score of over 4, or improved score of 2 to 3 with a positive D-dimer, and these patients then receive rivaroxaban or no intervention when they go home. And they have to be, of course, they're on low molecular weight heparin or unfractionated heparin in the hospital, but this is when they go home. And the idea is that we'll see whether or not this randomized trial shows the benefit of prophylaxis in these patients after hospitalization. One note about the direct oral anticoagulants during hospitalization: they're not advised. We can't do very much about certain patients as far as the DOAC is concerned, because they may be on antiviral medications, and that may interfere. And also, it's hard to measure them. And so low molecular weight heparin is recommended during hospitalization, particularly because it limits exposure of the personnel in the hospital instead of using unfractionated heparin. But once they go home, the DOACs have been shown to be very effective. So now, in conclusion, and I'm sorry I've rushed through this, but I'd like to have time for questions and discussion. COVID-19 thoughts. Perform risk assessment using your favorite tool. Now, for most of us, and here at Northshore, the first study to show the value of the Caprini score at Northshore was at Glenbrook Hospital in 1991, where Sandy Candosia, who is a member of our staff to this day, and Juan Arcelis, who was my fellow, teamed up in the morning on Morning Report, and they collected 500 medical patients and scored them, and 500 surgical patients and scored them, and clearly showed the value of the Caprini score in both medical and surgical patients to identify people who are at high risk of thrombosis. That advice was not really acted upon by Northshore in any meaningful way until COVID hit, which was at 2020. So 91 to 2020. And now there's a very excellent effort to introduce the Caprini score system-wide and produce an e-Caprini in EPIC, where a lot of the factors can be collected by the EPIC chart, and I applaud that. There's a couple of little things here that I want to mention about that, however, and all of us that use EPIC know that garbage in and garbage out. I can remember oftentimes, and I'll bet you Ben will agree, has had this situation happen many times. A patient will get a DVT, go to the emergency room, they'll get their drugs, and they'll say, call your doctor. They call their doctor on Monday, and the doctor says, oh, you got to see somebody. So they'll go and see a person like Ben or one of his colleagues or myself, and they'll say, I come in here, doc, to find out about why did I get this blood clot? How long do I have to stay on this medication? And how can I avoid getting another one? And the first thing that'll happen to these patients is that you'll ask them, and this is just an aside, well, tell me, how are you doing? Well, I'm terrible. I've been taking this medicine for 2 or 3 weeks, and my legs are killing me. Well, where are your stockings? Well, Chest doesn't recommend using routine stockings, and that's another story. That's my latest video that I just put on YouTube. And anyway, so the first thing you have to do is you have to put them into stockings, and then you have to adjust their anticoagulation to make sure that that they are getting the right compression and so forth. But I digress a little bit from what I want to say. Benjamin will look in the past history and look in the chart and the problem list and the diagnosis, and there's no DVT in there. What? I've seen this happen dozens and dozens of times in my consults for this. It didn't get entered. So if it didn't get entered, you won't keep track of it. So there's a little bit of a problem with that, but hopefully we can avoid that. Another really difficult problem about EPIC, as you all know, all of us are experienced, are copy and paste nightmares. Somebody takes a history, it's a weak history, and then it's copied and it's pasted. And then you get to see the patient. You got 15 minutes to see the patient. So you copy and paste the old history. Anyway, enough of that. Make sure that you encourage people. So how we avoid that is by patients getting and doing their, and I hope that Northshore will continue to work on this and make sure that when you have to sign up for a visit, either an e-visit or an inpatient visit, and they ask you about your insurance, they'd ask you, did you do your Caprini score at home? And here's how to do it, and put it online. And to me, that's as important as the financial. But anyway, in COVID-19, you have to understand the widespread involvement of the vasculature. Pulmonary thrombosis and alveolar endothelial damage are prominent features of this disease. And this thrombosis can occur anywhere. Also, you can get pulmonary hemorrhages. Arterial or venous thrombosis can occur anywhere in the body. And just because a scan of the leg may be negative doesn't mean they don't have a clot somewhere else. Tailoring of the anticoagulation to the level of patient risk is absolutely mandatory. Avoid one dose fits all. Perform ultrasound scanning for specific indications only. We do advocate point-of-care ultrasound testing. We do advocate not taking the big machines around the hospital if that can be organized. And post-discharge prophylaxis is required for high-risk patients. All patients need to be rescored upon discharge and need to be given prophylaxis for those that are at high risk. And I advise using the Caprini score for this purpose. So then I have a very dear friend in Maine who I spent a lot of time with. He's an academic dentist and a brilliant man. And he was on our daily walks And on these daily walks, he asked me about what's all this hubbub about the Caprini score. And so I told him. So he came up with this. And he said, Joe, I've got a saying for you. Never kill a friend, never treat a stranger. So what do we mean by that? Well, if you perform a thorough history and physical on this new patient you meet, then they're not really a stranger. You know a lot about them like you would a good friend. And of course, you would never kill a friend, and you would also never treat a stranger. And this thing has sort of gone viral, and they made T-shirts up and everything about it. But I think it's an important thing to remember. And it's most important as a critical exercise, especially during COVID-19. So I want all of you to think about doing your risk assessment scores, putting them in your, huddling with your primary care doctor, getting them validated, and put in your medical record in your Epic chart so that we have that information, and that would really facilitate what's going on at Northshore, trying to get the Caprini score in Epic, and all of the wonderful efforts that are going on to do that. So finally, I would like to thank you all for your attention. Please visit my social media sites, and if you go to YouTube, type in Venus Resource Center, and you'll see all my latest videos.